Okay, we are going to get started. Thank you all for being here. Appreciate you coming to this session. I'm Tammy Elliott. I am from KFMC Health Improvement Partners, and so happy to get this session, the Health Equity Summit wrapped up for the year. So happy to have all of you here. So today, this session is Empathy in Action, the ripple effects of SDOH screening on patient care. And I will tell you, we really struggled to get this session pulled together because people don't like to share until they feel like everything's perfect. And so this really builds upon Rhonda's session this morning, progress over perfection. You can do a little bit of SDOH screening, and even though you may not have data to say, oh my gosh, this is what we have, you have qualitative data, you've got stories to tell, you've got the impact you've made on patients and their communities and your communities. And that's really what this is about today, is even if you don't have hard, fast data, you can still show that you have had an impact on your patients and on your community. So even though you don't have the data to show in a pretty graph, we know you've made an impact. So that's what we want to talk about today, help you tell your story. So our objectives are to evaluate the impact of social drivers of health screenings on your patients and your communities using that qualitative data, and assess the impact of screening for and addressing those social drivers of health on your organizational culture, because it is going to change your organizational culture. So with that, I'd like to introduce Dorothy Rice. She is from Advent Health Ottawa. So I'm going to turn it over to you. Thank you, Dorothy.
Thank you. Well, I'd like to say thanks for having me first, and I know it's right after lunch, so hopefully you'll stay with me, and I'm sure you will. So I'd like to first share that at Advent Health Ottawa, we have known that healthcare disparities and inequities were a very top important issue. It is in the country, correct? And so we know that social injustice is many times what we look at as the issue, but also we all know that it's a quality of care problem as well. And so through things like CMS initiatives and the Joint Commission, we knew there were standards that we need to meet, but we also knew, more importantly, in our community, they needed us, and we have a lot of issues to tackle. So we've started that work several years ago, but have really ramped up in the last couple of years, I would say. So with that, Advent Health is located in Franklin County, and it's about 30 minutes south of Olathe, if you guys are familiar. And we serve about 26,000 in the county. And we have usually a census of about 25 to 30 on an average day. We do have 44 beds, as we all know. You're never at capacity, right? And we have about almost 13,000 emergency department visits a year. And we had 180 deliveries. This was all our 2023 data that I'm sharing with you. And so our outpatient visits are over the 100,000 now, and quite strong, as probably most of you are seeing. The inpatient population's decreasing while the outpatient's increasing. We are a designated trauma center, level 4, and we're accredited by the Joint Commission, and our sleep medicine program's accredited, as is our cardiac rehab. We are a hospital system now with Advent Health. We have 55 hospitals, and our headquarters is located in Orlando, Florida. But in Kansas alone, I think we have 8 hospitals now. Most of them are in that Olathe, Kansas City area, like Advent Health Shawnee Mission, Advent Health Overland Park, and Advent Health Lenexa, and Advent Health Ottawa. And so we also are in 9 states, and one of those is North Carolina that just got hit by the hurricane. We have a hospital in Hendersonville, and they had some effects of that. As Colorado's our newest in the Rocky Mountain area. We have, I think, 8 hospitals in that system. So we're in Kentucky. We're over many places. So a little bit about Advent Health for you. So Advent Health has been recognized as a great place to work. We got that award in 2025, and they were also, I didn't put that in here, but they were recognized for the best IT place to work as well. We have an awesome IT team that works with our Epic as our EMR. And so we've also been at Advent Health Ottawa ranked as the top 20 rural hospital and the top 100 community hospital. Our trauma designation I already mentioned, and we're a woman's choice for emergency care and high five for mom and baby. And so I also just wanted to share to you more recently in 2024, we've gotten our geriatric accreditation, and that came from the American College of Emergency Physicians. And then we're working now on getting our pediatric accreditation. And we also feel that safety is important, and Leapfrog, as you all know, is very high on the patient safety arena. And so we are Leapfrog A and always strive to maintain that. And Advent Health, importantly, has a promise, and I didn't put this here, but I want to mention it. Their mission is to extend the healing ministry of Christ, and that is a big, tall order, right? But that encompasses so many things, and I love and appreciate that, because inequities are so huge. As we all know, Jesus served everyone. It didn't matter what walk of life they were, so I think that's important. But at Advent Health, they look at the diverse workforce. We have a very diverse workforce. When I was Ransom Memorial, I'm not knocking Ransom Memorial because we had some great things, but we didn't have the diversity we have today, even in little Ottawa, okay? And so they build it starting with their employees, but then for our patients, they're advancing equity, also having those diverse populations and making sure that our patients are whole in body, mind, and spirit, not just the physical medical need. So, and then here's just a few visuals that I wanted to share just to give you a flavor of how I know that they're elevating it. And this is throughout our system that we focus like on, we call it Take 5, but Black History Month. They stop to take time to educate day after day for all of our employees about the history back to slavery and why we are where we are today, and the inequities and the things that we need to consider, really trying to provoke our staff to think and to, get outside of our own selves in a sense. So, but also this month's Hispanic Heritage Month, so we're learning about that. But we had Asian American Month, and so they're always displaying, and you all know, everybody's got a month now, right? Healthcare in itself, nursing month, or pharmacy. So anyway, a lot of celebrating, so that's awesome. They also do a lot of missional work. We've had trips to Peru, trips to Africa. Every year they're taking groups that want to go and participate. They support the staff, and then the staff puts in some money of their own, and everybody that goes is so fulfilled in helping those that don't have much. And especially in their health needs that they never get, dental care and so on. So, and then that last one there, well, I guess a couple of them, we've talked a lot about the food insecurities today. So we're very involved in our community. We have the blessing boxes that Rachel speak about. And in Ottawa, I'm proud to say we have 10, which is pretty good for the size of Ottawa, but we know we don't have enough. We need to build. They're always empty as soon as you fill them. And so we're doing drives, food drives all the time, and really getting people to get involved with that. And then the last thing is the shoes that fit. We've done this project for several years. We actually look at the kids that have reduced or no lunch payment required, and we make sure that every child that meets that has a pair of shoes and 5 pairs of socks. And this year we chose to go into the school that has 65% of their kids meet this level. And we gave all the kids at the school a pair of shoes and to go and be a part of that. The kids just light up and are like, I've never had a pair of shoes, or they will, just really amaze you with their responses and appreciation. So it's a very warming thing to be a part of. Okay. So then our health equity here, I just wanted to mention, it's achieved when every person has the opportunity to attain their full health potential, and no one is disadvantaged from attaining this potential because of a social position or an other socially determined circumstance. We talked about that this morning. I thought our definitions were right on with the groups, and that's very much what it is. So what are social determinants of health? You all already know. We've talked a lot about this, so I won't read that to you, but I do want to point out what the slide is telling us. 80% of social determinants of health are not healthcare access and quality. It is social and economic factors. And again, I don't know if that number surprises you. It did me, 80%. And when you stop and think about that, so yes, we all know access is a problem. That's just 20% of it, though. We still have a whole lot more work outside of the hospital, in my eyes, that we have to do to help them even be able to get the 20% that they need. So a lot of work to be done. And this here, I wanted to share with you just real quick that I'm very pleased to be a part of Advent Health, because years ago I was manually abstracting all this data and trying to do it myself. We would do readmission work, and I would break it down by race, and we would call it frequent flyer. I don't like that word anymore, but and then look at payer source and all these other things manually. Well, now with Epic and the work of our IT team, that's truly awesome, they can break down all this data for us. And so this is just a glimpse for you, like this on the slide, on the left side here mainly. For Ottawa, we're not real diverse. We do have like a 98% white population, and then the 2% is Hispanic, Black, Asian. And that's what we see typically in the hospital. We might bump up to 4% on occasion, but most of the time it is truly heavily a white population. So with that, though, we know we even more so have an important job before us to make sure we get the Hispanic language availability or the Asian language, and we have our tools to help the staff be able to call right away if they need to speak to someone, or even deaf. You know, we will have deaf patients that we need that ability to be able to talk with them. So we have had lots of work in this area looking at our own data. This will break down to several other things. I just gave you an example there. This one I'm even more proud of because my staff are directly involved with this. I have the quality management team at Ottawa, and we're doing the social determinant of health questions. And so when we started out, my staff were very uncomfortable. I have to tell you that they were like, this is uncomfortable trying to ask people these questions, and they're uncomfortable, we're uncomfortable, and we had to just stop, and say, we've got some work to do. We need to start having discussions. That we would have huddles, we would talk about inequities and why we need to assess these things, and how we may go about scripting to the patient and not be scripted. And so looking back at that to today, they have come such a long way with that. It's now what they do. They want to do it. They love assessing their social determinants of health because they're identifying things that they can then feel like they impact. Now, I will not stand here and say we've got it all figured out and we have all the resources that we need, because we don't. We struggle in Ottawa. There's no housing. There's not even enough housing for those that can afford it, let alone those that are homeless and need, a solution. So we pull together with like our Hope House and our ECAN and other community partners. And when it gets winter like this, we may have to put them up in the Knights Inn for a few days, or whatever we can do. We try to get creative and figure it out. And that's way different than it would have been 10 years ago, when it was like, you got to go on and figure it out. We don't have anything to help you with that. So it's really changing, and it's changing for the better for patients. And so I'm glad to see that. But I did want to point out on this slide before I leave it that my staff are hitting 99% screening pretty consistently, as you see. So they've got it figured out now, but they would be the first to tell you that they don't feel like patients are still forthcoming. They're ashamed or don't want to answer those questions sometimes. And so this number, we believe, is way low. And you guys had data earlier that said, I think it was 7%, if I remember right, in the United States. And we're at like, what, 4% for food insecurity. We know that's low. We know it is. But even if you figure that up in the Ottawa area, that's about 1,000 families. So when you think about that, that's still horrific. But when you say 4%, big deal, right? But no, it's a lot of people. And we have food pantries. We have the Hope Bus that Advent Health does, that we bring the bus in and we take it out to the other towns in Franklin County as well. And they get fresh meats and fresh salads and vegetables and healthy nutritional options. And we do harvesters too, and they get that routinely. But we try to, with the Hope Bus, to give some more fresh options and strive to teach about the healthy side for them as well. So again, we have lots of work yet to do. But we all know, again, what health disparities are. So I won't read through all of those, but I do want to give you some examples of this. So adults experiencing poverty are 5 times likely as their peers to report poor levels of health. Lower income Americans have higher rates of chronic conditions, including heart disease and stroke. And we see that. We just did our community survey again, and that was what rose to the top. Cardiovascular was our number 1, diabetes right behind that. Nutrition was a big deal. Everything we're talking about today, and I bet it would be in your communities as well. And then maternal and infant mortality, we've talked about that today. It's a huge problem, and we need to keep addressing that. I'm glad to see the collaboratives and things going on out there to help in moving this work along. And CMS is pushing this work along now, right? So, but our infant deaths are twice as high for the non-Hispanic Black and the Pacific Islander babies than like Asian babies. So it's this work we need to keep collecting our data and seeing what it's telling us. And then Black women are disproportionately more likely to die from breast cancer than women of any other ethnicities. And so Black men are more likely to die from colorectal cancer than any other men of national ethnicities. So just some little stats that I didn't know. I hope that helps you all in some way. And so at Advent Health, we have a DEI council, diversity, equity, inclusion, right? And we have an health equity plan that we've established out of that. And we share this same group of team members between our DEI council and our community health planning committee, which is the one that we just did the survey for again recently. And so these 2 groups can come together, and we're tackling issues from many angles. And so we have to identify constantly what our issues are in the data, what's it telling us and showing us. And then we're trying to come up with solutions for that. And then more importantly, measure it. Are we making any difference? And this is another dashboard. I say I love Epic and I love Advent Health for IT for our wonderful dashboards. It pulls it all out of there for me, so I love it. But in here you could see, without reading all of it, that we have data and dashboards that are helping us stratify our quality data and our equities. And we use the demographic data from your age groups and gender and the economics, several things that we can see from our zip codes and where it's landing. And it's amazing to get all of the data, and it's helping us drive what we're doing. So out of that came some top areas of opportunity for our Mid-America region. Again, many of the hospitals I've mentioned to you that are in our Advent Health system. And so we started to look at disparities in the inpatient outcomes. And we, again, we're breaking down the race and ethnicity and all. And what we saw was two kind of rose to the top. One of those was surgical urologic problems and sepsis. And so we chose to focus on those, particularly in the female population. We were seeing more disparity in there. So we picked those, we established our plan, and what we found out on the urology side, after we set our plan, we had no complication for months, okay? That was okay for us. So we have continued to collect that data, but I can tell you we will end that as of 2023 and move to another. But sepsis did rise to the top, as it's everywhere, right? We all have opportunity. It's probably the #1 issue in every hospital. And so we chose to focus in and do tons of work this year on sepsis. So we created a code sepsis team, just like you would do a code blue team or a code stroke team. Our sepsis, when we have a patient hit the ED, and we know it's triggered right now, Epic does great with that. We call it out, and we have a team come, and we're getting blood cultures and antibiotics and fluids started right away. And we've been working on this, and we have moved our 3-hour bundle from 72 in the first quarter, 83 in the second, and we just hit 84 for the third quarter. And so we're moving the needle, but it's not good enough. And so we are going to go back and have that happen in an hour. And so we're really hitting to minimize the septic shock with it progressing further. And so we're excited about that. But in addition to that, we have a whole code sepsis order set, and the doctors weren't using it. So we brought in one of our champions from Florida who's worked a lot around sepsis, and he's a physician. And so he worked closely with our physicians on the reasons why they would improve outcomes to use that order set. So they've come up and are doing better. They don't have it 100% yet, but we're making progress and we're pleased about it. So, and then the last thing was we did heavily community education and awareness around sepsis. And again, I know we need more and more and more. People just are not aware of what that is or what that means. So we continue to work on that one. And then I will just end with saying that we know we have lots of work yet to do. I feel like we've just started this journey, and we don't have it all figured out. And I know many of you have your stories and can stand up here and tell the many great things you're doing. All I can do is to challenge us all to keep trying, keep collaborating, not cooperating, right? with your community partners, because that's how I have felt has been the big change for us. It used to be within the hospital walls. And even myself, admittedly, would think, how's this a hospital problem? Why are they putting this on hospital? I mean, I'm just being open and transparent. That's how I felt way back. And so it's very much all of our problem. If we're a part of our community, we need to help figure it out. And it takes all of us. It's no one entity's problem. It's not the health department alone. It's not the physician office. It's all of our duty to do. So with that, Advent Health Ottawa thanks you, and I thank you for staying awake. And we have Tammy next, so I'm going to turn it over to her. All right.
Okay. All right, so I am from Nemaha Valley Community Hospital in Seneca. Okay. Better? Okay. So Nemaha Valley is located in northeast Kansas. We are 12 miles from the Nebraska border. And we have a small 24-bed critical access hospital. Right now, we are in the middle of a build. So we look a little messy right now, but, oh, there we go. So we've got a new inpatient wing that is coming to be open hopefully by the end of the year is what it's scheduled to be. So we will see how we do with that. We were also recently named a top 20 hospital for the NRHA, and our county is a little unique in that we have two, for a county of 10,000 people, we have two hospitals in our county, so that's very unique. And just wanted to show you a little bit of just statistics here. So we have certainly seen an increase in our Hispanic population in Nemaha County. I just have the 2010 versus the 2020 census data up there. So in 2010, Nemaha County had a 1.2% census data, and in 2020, we had a 2.6% census data. The statistics we certainly, as a hospital, have seen a rise in our Hispanic population. This particular patient that I'm going to talk about was planning to deliver in our hospital, but she then later, she was having some more high-risk things and ended up delivering elsewhere, but we certainly did provide some care to her. One thing I really think is interesting about these statistics, the preferred language, I can assure you it is not 0.7% of our Hispanic population prefer English, prefer Spanish over English. But I think when you ask that question saying, what language do you prefer? I think they just automatically say English. And truly it needs to be, what language do you speak at home? But when our registration ladies ask that, that's the way it's worded in our system. And that's kind of what they've been ingrained to think. And we've tried to do some education around that, but there's more education yet to be done. So, all right. So I would like you to meet Louisa. She first came to us for obstetric care in 2023. She established care with our providers, and then, like I said, she ended up delivering at a tertiary facility, and she came back for breastfeeding assistance, postpartum assistance, and she was new. She was from Venezuela. And we were able to help her get some charity care. We have a program called Baby's Best Start that is our local hospital collects different. We do like a baby care drive for if they qualify, they are able to get those resources for up to a year, and there's a certain dollar amount. So we're able to give her some Baby's Best Start items, and she was also able to get some WIC, things like that. So she loved our OB nurse manager, our OB manager. She told me, Miss Dana is just a truly wonderful person. She has Louisa had some postpartum depression, and she was able to help her get counseling. So we don't have a Spanish-speaking counselor, and to have her try and do telehealth would have been like a telehealth with a Spanish telehealth. It would have been a heck of a mess. So we were able to work with the Kansas Perinatal Quality Collaborative to find a Spanish-speaking counselor for her. So she was absolutely so thankful for Miss Dana. Mrs. Dana is how she told me. Mrs. Dana. When I met Miss Louisa, she had she had sent a contact us email from our website. So our IT guy got it to me. Actually, he sent it to HIM, and HIM sent it to me. I help with the patient portal, and Miss Louisa was wanting to get on her patient portal. And she was not able to get on the portal. and the HIM lady called me like probably 5 minutes before I was leaving on a Friday afternoon. I had things going on. I was like, well, here, I'll send you this link. Here's the link that we can just get herself enrolled. I didn't know Louisa was, I didn't know who she was. I didn't know if she was Hispanic or not, or I just thought, well, she'll be able to get on self-enrollment. And so anyways, I quickly found out that was not going to work for Miss Louisa. She contacted me back with a screenshot saying she was not eligible to enroll on the patient portal via self-enrollment. And so I thought, okay, checked it all out. Well, it was because we didn't have a social security number on file for her. And I thought, well, okay, I'll reach out, and I got her on the portal, and I was explaining to her why it didn't work was we did not have a social security number on file. Well, she thought she'd just send me her social security number via email, unprotected email. And I was just like, oh, goodness. I said, well, thanks so much for sending us that information. I'll make sure and add it to your chart. I was just like, oh, not a good idea. Anyway, I quickly learned that was, there was definite language barriers there. And so I had been working on our health equity, and I just thought, well, I'm just going to ask and see what we could do to make our hospital more user-friendly for her. And so I just, I could see it appeared she was using Google Translate or something with her email. And so I just asked her, I said, we are brainstorming ideas to make our hospital more user-friendly for our Spanish-speaking population. Would you be interested in helping me do this brainstorming and help me come up with some ideas for the hospital? And she was just so grateful. She goes, oh, this is an excellent idea. And she goes, I will absolutely collaborate with you. There's that collaborate word again. So she was willing to answer any questions that I could have. And she said, the truth is, it's necessary because there's many people in need. And there was many people that she was well aware of that did not have some of the resources they needed. She also said that communication was very important, and that most of them do not speak English and only speak Spanish or understand very little of another language. Her husband and her school-age son were able to speak some English, but she had not yet had a chance to learn. She had the new baby at home. She had, her family. And so anyway, I just began to ask her, what would be helpful? How could we do better to help your Spanish-speaking Latino population? And she pointed out very quickly that our website did not convert to Spanish. I'm like, oh, that's very helpful to know that. You kind of get your eyes opened to the different needs. And it's such a good thing to have our eyes opened to things that we just take for granted. So anyway, that was our first thing. And she also pointed out that she was coming up with errors on our bill pay. And it didn't convert to Spanish. And so that was another opportunity. And then she also was asking about being able to get an appointment in Spanish or request an appointment. Well, I quickly found out that our portal was only half built in Spanish. Little did I know. I thought our EHR finished it when we implemented it many years ago. It was not. So I converted my own to Spanish, and then just started looking at the different icons and had to do some screenshots and send an SR to our system so that we could figure out what exactly was going on. Anyway, she also said there was assistance programs but she couldn't tell if she still qualified because they were not in Spanish. She knew we had the Baby's Best Start because she'd used that. She didn't know how long it lasted. She couldn't tell if she still qualified. It is only for the first year, but we did actually, we were able to help her a little bit. And she just said, this information will be very important for many. And so just making sure to just printing education in Spanish, because if we don't print it out in the clinic, it automatically flows to the portal in English. Things like that we didn't know. So we're just kind of learning as we go. I asked her if she had any immediate needs, and she said she had a need for diapers. And so that was the first thing that we worked on. And so we got her some diapers. We had our largest size that we had in stock with our Baby's Best Start was what her child was in. So we were able to get her a couple of packages of diapers, and then we were just started to see what else we could do. We just became good at using Google Translate to kind of communicate via email, just to see if we could, she could help me and I could help her, and we could kind of brainstorm together. And I just really felt called to help her. Let's see, did not, I thought it switched, there we go. Just really felt called to kind of help her and her situation. And I asked her again, like, what other resources can we provide? She had asked if there was basically like social determinants of health type questions is what I was asking. I didn't do a full screen. I just started asking some questions to see what I could do. And we were able to get her a list of the basic social determinant of health type resources. So I provided her with our food pantry hours, when our harvesters bus came, the hours and phone number for our transportation bus, the cost. You can get $1, we'll get you 3 stops. Let her know some of that, our schedule for our Catholic Charities bus. Our mission center that is run by the Catholic Church has a large variety of housing or items for the home, as well as some clothing items. And she was very familiar with that. She loved the people at the mission center. She said they were always very helpful. And I asked her if we could just continue to work with her. And she was very happy for that. And we did consult our community health worker. And our community health worker had said she'd been trying to really find more opportunities to work with the Spanish-speaking population. And so I said, ask Luisa. I think she could probably get you a list of people that could use some services. So hopefully she's been able to take advantage of that. I've not been able to talk to her lately. But like I said, I logged a service request with our EHR. I talked to our PFAC about ideas. And our PFAC was absolutely, they were like, yes, please use her as a resource. I've not had her join our PFAC officially. She's got the small child at home and she can't get away to meetings, but she is absolutely my go-to person for our PFAC. We talked about this at our quality meeting as well as at our board meeting. So I brought this to our board. It just happened to be right before I was going to go speak to the board. And so I was like, well, here's some ideas that I have. For example, do you know our website doesn't convert? And just gave them a little background, and they were just really open to working on these ideas to improve our care for them and access for them. So we are just continuing to work on different ideas as I come up with an idea, I run them by her or just bring that to her attention and to see what she would think of something. So it's been a great partnership, and I've just loved getting to know Louisa. I did later find out that one of our registration clerks had also built a rapport with our Spanish-speaking population, and she was also using Google Translate on her phone because when they were calling in, they were having a hard time, figuring out all the information she needed to add in. So if she texted it to them, then they could certainly answer back. So she ended up becoming, unbeknownst to her at the time, a liaison for the Spanish-speaking population. So she quickly got her phone number shared, and she now has been assisting everybody with getting appointments scheduled. So she's been very gracious, but we do also have the iPad for translation services. Most of the time they use that in the building for their appointments. They use that daily. We have a program that they really do like, and they use that quite a bit. But the registration piece has still been a challenge for them. So, anyway, she has just been extremely just thankful and grateful, and she has shared all of the resources that I have given to her. She has shared with her friends and family and Spanish-speaking people that she is friends with in our area, and we will just continue to build that, and just really builds the trust with our Spanish-speaking community and builds rapport. Like I said, we've definitely seen an uptick in our numbers of our Spanish-speaking population coming to the hospital, and so we've been able to work with more and more. Hopefully, like I said, that kind of opened the door to our our community health worker working with the population. And just as I shared more with Louisa and she shared more with me, she told me a little bit about herself. And I just thought this was really profound. In Venezuela, she was teaching university level classes on research methodology. Just like, wow, this is an extremely smart woman that is having a hard time buying diapers. Yeah, navigating websites, navigating, life, not because of lack of knowledge, not because she's not smart, there's too many barriers in the way. So in Seneca, she's working as she does beautiful artwork in resin. I found out that I had actually met her uptown at one of our little, second Saturdays. I was like, oh gosh, yes, I know exactly who that is. And she's also recently become a nail technician for manicures. So certainly not using the level of knowledge that she has, but she is doing the best she can at this point in time. She was just very, very grateful, just always expressing her gratitude. And I was just, happy that we were able to help her and continue to help her. So, and that is my contact info. Any questions?
I have a question. I just wanted to say,
Hold on a minute. We're on Zoom. We have to have the microphone. I'm not doing it in the face, Tammy. That would be very rude.
yeah. I just want to thank you both for bringing the perspective of how just even, interacting with one or finding even a small percentage of your community that might sound like a small percentage turns into 1,000 people, or even one access point. So we can all make the difference with just one person. The example I have recently shared is I had a housekeeper for 3 years. She, just like Luisa, had a different story for her previous life. She was a nurse in Mexico, but she went back to school here and became a CNA and is finishing CMA school. So I actually had to fire her as my housekeeper to make her go find a job, right? So then I reached out to her like a month later and I said, so tell me where you're working, because I gave her a list of places to go work. And she said, no one's hiring CNAs. And I said, oh, yes, they are. I said, come to my house. And we did a resume and we did. But you know why? She was going on your websites and you have them listed as careers. And someone who speaks Spanish doesn't know that word is the same synonymous with job. And so I sat there, and so she said, I am embarrassed to admit that I don't know what a resume is. I'm embarrassed that I can't go to their portal. See, that's the deal, is people were sending their portal links to go and fill out this extensive stuff when in reality you needed, how much information for her. I printed out her CNA license, her CMA license, I did all those things and I took a letter and I said, let's just drive. There's 2 places here in my town that I know are hiring because my 17-year-old works at one and then I know people that work at the hospital here. Let's just drive. Both of them offered her a job that day. But so you got people in your communities too. She's bilingual. I mean, she even speaks English. She was 5 when she moved here originally and then went back to Mexico. So, I mean, she knows English, but not obviously as well as to translate careers, opportunities. I mean, some websites have it listed as opportunities. So there are people in your community that, like you said, just hidden talents when we're all also looking for resources and diverse workforce, but we just haven't phrased it right too. So I thank you both for sharing your stories too. Thank you.
Thank you for firing her.
So to Susan's point, the one thing that really resonated with me is you interacted with one patient. And, Dan talked about moving at the speed of trust. She trusted you. Her community members also trusted your registration clerk. And because of that trust that you built, you're impacting their community and they're impacting your ability to serve them by giving you that feedback. I also really love the idea of using her as an ad hoc PFAC member, because I know I've been on a PFAC and it was really hard to get a diverse population on that PFAC. And so to be able to, even though she can't attend, to be able to get her feedback and things like that. So, Dorothy, I have one follow-up question for you. You talked about you've got your screening rate up to close to 100% now. Did your staff experience implicit bias within their screening when they started? Like, oh, I'm not going to ask them that question because they have this job, or I know them from the community, or things like that. So can you talk about that? Was that a factor, and how did you mitigate that?
Yeah, definitely implicit bias initially. And we had to just keep talking through and educating about inequities and the many considerations that we need to think through outside of our walls, not just about healthcare, and just discussion. Wherever they wanted to take it, we would huddle and we would talk about it every week, sometimes 2 and 3 times a week. And they would go back to the drawing board and do more. And it just slowly by slowly became more comfortable to them, to where now it's like, I don't think they'd want to do without it, So, yeah.
And I think when you and I first talked, you really talked about the change in the perspective of your staff. Whereas before it's like, I don't want to ask them these questions, but all of a sudden they're like, these patients are coming up from the ED and they already know they have this need, and the nurses and the rest of your staff are already thinking about how do we address this need, rather than just like, I don't even know what to do, so I'm not even going to ask the question. So I think that's really cool. Of course you do. That's okay.
So Dorothy, you also talked about how you already feel like you're not getting enough honesty or trust or connection. And I'm not trying to put words in your mouth, but that you'd already feel like some of the percentages are too low. Have you thought about ways to just share resources regardless of their answers? That's what I've been advising even smaller organizations when they come up with a resource document or a QR code or how they're getting their resources packaged in their community. Even if the superintendent's wife doesn't say yes to feeling unsafe at home, how can we just get resources out regardless of how you answer my questions? What are ways to challenge that? Knowing if you already know that your yeses are low because of comfort or trust or whatever, how can we cross over and just give them anything that might be needed, not only for themselves, their families, or their communities?
Good question, Susan. That one we are tackling through, and I can't take credit for this, our health department put together a resource guide some time ago, and they just recently updated, and it's an ongoing, every month it changes, right? And so we have it on a card and it has a QR code. We find that not very many really want to deal with the QR code, but we're giving them that, and they can actually get to the resources from mental health, food pantries. I mean, the list goes on and on. Hope House, which has clothing, shower available. I mean, it's a lot of stuff, but to that point, if we don't know, at least we're giving some information if they have a need and we haven't identified it with them. So.
I don't have a question, it's just a comment as I'm thinking about Susan's story of the housekeeper that, didn't understand what these words meant, and your story with Louisa is that we are in the process of getting new PFAC members. And so a comment that I wrote down for myself is, are we trying to cull the members of the community that are from these groups? Because that's their voice to tell us. I would have never thought they don't understand what career means, and yeah, that's what our website says. So I need input, and I wouldn't have known how do I figure that out? How do I find that out? So maybe a PFAC or some, if we're building those in your hospital would be one avenue to get to those answers.
Okay, we've got 10 more minutes, so yeah. You guys have lots of questions.
I don't know if this is more of a comment than a question, but working in the field directly, and I'm not doing that right now, but just throughout the history of my 28 years in nursing, I find it very interesting that you need to be an advocate for those patients with your peers also, because there are lots of people who are just frustrated or don't want to take care of that or take that extra step. And to be an advocate for them, or to even, have people involved to be advocates for that or be parts of committees to make that something that becomes part of the culture. It's a very hard thing and a big shift to do, but I've had many stories just like the ones you shared too, and this is just a topic that is becoming something that we weren't all talking about before. And so it's really been good and great to me for that to kind of come around and have conversations about it.
Yeah, for sure. Other comments, questions, maybe things you've done within your organization?
I am a community health worker, but I'm in an ambulatory clinic, and we know that when those screeners go out, those patients aren't being honest with us. But then I can get them one-on-one, and I can get them to talk. And even though we don't bill for my screen, we only bill for the one they did with the provider, we still go off the basis of my screen is more accurate, and those are the needs that we're going to fill. So that's one way that we have taken that on. Another one is whenever we offer like our diabetic prevention program class or our Healthy Heart Ambassador program class, we have everything out that they can pick up if they want about all the resources that are in Sedgwick County. And then a lot of stuff that we find, we've been just putting it on our website. And we've been getting lots and lots of likes on our website. We don't know who's liking it. We don't know if they're using it, but we know it's being at least liked. So it is, those are other ways to put it out there too.
And I really like the idea of kind of that double screen, knowing that they're going to be more comfortable with someone from their community, someone, that's the whole point of community health workers, is really having someone they can relate to and be fully open and honest with. So acknowledging that, yes, this provider screen is great, we get reimbursed for it, but then really looking at, this is the true needs of this patient. Yeah.
And if you're able to be in the home, I don't know if you are, I think that would make a world of difference too.
Yeah, screening them where they're at. Yeah, absolutely.
I can't remember if it was last year or the year prior at this conference where somebody gave the example that they felt like they were not getting enough positive screens when they were verbally asking the questions, but when they did paper and left it, the patients were answering more honestly. Does anyone have thoughts on that instead of reading the questions and I'm not saying humbling, I'm not saying that in a negative way, but do we think that they would be more honest to have someone do piece of paper screen instead of having to admit to someone? I don't know, but I mean, I do know it was during this conference, I just can't remember which year, that somebody said they tried it, they thought they were doing great, they were at 100% almost of screening, but they felt like they weren't getting the trusting answers, and they felt like when they went to paper, they got more honesty. So I just didn't know if anybody had personal experiences on that.
We have our social worker that goes so we haven't been doing a lot of that in that clinic, but when social worker has better like pulling those and around. Well, I could tell from the nurses yeah, I mean, and that was one of the big things that I pointed out to people, because you can hand them a piece of paper, but yeah.
I was going to say I've done both, and it depends on how you set your person up for the questioning, and how, if you tell them the whole details as far as what the process is and what will the outcomes be if something is flagged. I think it makes them feel more comfortable and more able to relate to you and be more honest with you. But I also find it very difficult sometimes too, again, the education level or the mentality level as to, can they hear me repeat the question and the answers to give me the appropriate answer? So sometimes it's kind of a catch-22. You do but one for one and another for another. But again, I think it really, really does make a difference. And I've had nobody, and I mean nobody, tell me no as far as answering my questions. And I feel like I do get 100% honesty in how I present, because I sit there and tell them the whole shebang. I said, if there's something that flags, we will take it back to the committee. And I ask them for permission first. If I see something, I'm going to flag it. I may ask you some more questions. It gives me a chance to delve into the area, like meals, nutritional stuff. What is the problem? Do you not have the cookware? Do you not have the means to do it? Do you not have the strength to do it? What is the issue? So when I go back to my group to discuss this, then I have more more information to hit my group with to get the resources to them. So.
Thank you. That was really insightful. That was very good information.